Hi, I'm Meredith Munn, and I was a part of Group 3, and our topic was problems with COVID-19 models. My group members are Justin Lee, Stephen Esposito, Mary Cochran, and Riley Collins. The first question our team was asked to tackle was, why did the various COVID-19 models fail to predict the real magnitude of disease spread and impact? In other words, what's wrong with these models? And so we felt that it would be most advantageous to first explain the common mathematical models used during the pandemic and then explain their failings. The first model is the Sears model. This model divides the population into four categories, which are S, susceptible, E, exposed, I, infectious, and R, recovered. The susceptible compartment is composed of the number of people who can contract a virus at a given time. This includes almost everyone except those with antibodies, as we found with COVID-19. The exposed compartment is composed of the number of people who have the virus in them but cannot spread the virus yet. These people then move to the infectious compartment, which is the number of people who are contagious at a given time. Following this, the R compartment is either the people who recover from the virus or unfortunately die from the virus. People can move back to the S compartment when they can contract the virus again and are no longer protected by antibodies. As we have found with COVID, people are able to move back to the S compartment in some rare occurrences. Then complex differential equations that I will not get into are used to determine how many people move from one compartment to the next and therefore estimate how many people are in each compartment. The UK's MRC Centre for Global Infectious Disease used a version of the Sears model to model the pandemic in 11 European countries. They used the death count to back calculate the number of infections and to draw conclusions about the policies made in each country. This model is used throughout the world, but the UK serves as a prominent example. Next slide. Unfortunately, the Sears model failed to predict the magnitude of COVID-19 because it was based on assumptions that led to inaccurate predictions. These assumptions were that the population is homogeneous, people mix evenly, and everyone is equally as likely to contract the virus. As we know, these assumptions are obviously not true. As we have seen with quarantine measures, some people follow them and some don't. Some people gather with their families and friends, and others live independent lives, even pre-COVID. Therefore, people do not mix homogeneously. Also, as our knowledge of the pandemic grew, things like age, medical history, and location were recognized as factors that significantly impacted a person's susceptibility to COVID-19, as well as the severity of sickness they experienced. According to the CDC, more than 80% of COVID-19 deaths occur in people over age 65, and also health conditions like cancer, chronic kidney disease, COPD, diabetes, HIV, obesity, and so many more make people more likely to get severely ill from COVID-19. As other presentations in this class have mentioned previously, socioeconomic status and race are other factors that contribute to an increased risk of getting sick and dying from COVID-19 due to the inequities in healthcare and in society overall. Next slide. The next model we investigated was the agent-based model, which was a more robust model than the Sears model. The reason it was more accurate was that it does not make the same invalid assumptions. The agent-based model includes demographic characteristics such as age, medical history, socioeconomic status, and more that come from the census. Computers then simulate the interaction between people, agents, and can input disease characteristics like transmission rates, percent of people who are asymptomatic, and more. The researchers then use the data that is produced by computers to make estimates of hospitalization, death, and infection rates. One prominent country that used this model was Austria. It was found somewhat effective for the analysis of social distancing and lockdown policies. Next slide. The failings with the agent-based model were that data changes and is still changing rapidly throughout the entirety of this pandemic. We did and do not know the exact transmission rate nor the number of asymptomatic cases. Also, it was unknown for months if reinfection could occur. The massive amounts of data required to accurately make predictions was not accessible, especially at the beginning of the pandemic. The fact that this model requires extensive computational power that many places do not have access to is a barrier as well. Next slide. Overall, the general issues and limitations of mathematical models as a whole did not have as much to do with the models themselves. The major issue was that there was a lack of accurate data since there was a lack of testing. The case count was difficult to measure, and people didn't follow our expectations for their behavior. The first problem was that there was a lack of testing. In an article by Modern Healthcare, they stated in May of 2020 that it had been 4 months since the since the first COVID-19 case was reported in the US, and the demand for testing for SARS-CoV-2 virus far outpaces the supply. Also, developing tests that were both quick and accurate was a challenge. Another issue is that it is extremely difficult to estimate the proportion of people that are asymptomatic for obvious reasons. This thus made the case count exceedingly more difficult to calculate. Besides testing difficulties, some hospitals' decisions to withhold their numbers contributed to inaccurate estimation as well. In my opinion, the largest problem with making predictions is that people did not follow what we thought they were going to do. When COVID-19, a global pandemic, became politicized, so did the public health policies. A quote that we thought summarized, next slide. A quote that we thought summarized the overarching message in our research was from an article in the New Yorker that was in our assigned readings. The quote is, "We should accept that there are inevitable limits on what numbers can offer, and to stop expecting mathematical models on their own to carry us through times of uncertainty."
All right. Thank you, Meredith, for that in-depth analysis on some of the individual models. My name is Justin, and I'll also be talking about what went wrong with the models as well, but I thought it would be interesting to also look at what went wrong with our overall approach to the models and also the way in which we communicated information based off the models. So the first thing that we should have been more cognizant of was the amount of unknowns at the beginning of the pandemic. We did have a lot of data from China and Italy when they were first hit, but a lot of people felt that this data was unreliable. And so some of the questions that were still up in the air included attack rate or how many people get infected in a group setting, whether or not there's immunity after recovery, how widespread asymptomatic cases were, how infectious asymptomatic cases were, and what the rate of our false positives and false negatives were in our testing system. And because of these unknowns, we made a lot of assumptions similar to what Meredith mentioned earlier. And with that being said, we should have been more adaptable and agile with our models and our model production. So instead of just relying on one model and following that model specifically, we need to be faster about producing newer models and also including a more diverse variety of models in order to best inform our decisions. If we were to be more diverse in our model choices, we would have had a much more holistic approach to the pandemic. Each model has their own advantages and disadvantages. So they'll each have their own purpose and will therefore inform us about different things regarding a certain issue. For example, as Meredith brought up earlier, the SARS model was really good at making simple long-term predictions, but the disadvantages came with setting the parameters based off the real world with how people were acting in the public. With machine learning and data-driven models, they're really good at making accurate short-term predictions and also computing through really complicated factors, but there were a lot of issues that came in when certain conditions changed. So overall, just being more cognizant of each of the models and what they can provide us, rather than using a single model would be much more useful. And also because parameters are always changing and new information is always coming in, we need to be more agile with our model production. There have been a lot of software development advancements within the past few years. So we should have capitalized on that. And with platforms such as GitHub, data scientists and computer scientists would have been able to communicate with each other much better and collaborate much quicker. So these newer models based off newer information should have been produced much more quickly. And just in general, with more model production or faster model production and a more diverse group of models that we base information off of would be able to guide us better, or would have been able to guide us better. And with all that being said, there should have been a different mindset when it came to interpreting these models. Instead of basing one single certain possible future off of a model, it's better to consider all the possible futures that a model provides and slowly over time remove impossible futures as they qualify. Conditions are always changing, parameters are always changing, so possible futures will always be changing. And this in turn will make communicating information to the public much better. Throughout the pandemic, as we know, there was a lot of miscommunication with the scientists and the public. And when it comes to models, we really need to consider the public because its behavior and how the behavior of the public really plays a big role in the parameters that get inputted into the models. And a lot of that has to do with the expectations that came from the public and their expectations for what the scientists would say about their predictions for the pandemic. The pandemic really hit their lives. So it hit their lives pretty hard. So they would be pretty judgmental in terms of like how accurate, or when decisions were made based off of when decisions were made based off of a single model, and that model ended up being wrong to the public, it would create a lot of distrust in science as overall. And this was just because the pandemic hit their lives so hard. They would be very judgmental about these sort of things. And overall, we know that models aren't supposed to give us the right answer when it comes to decision making. They just represent what could be going on and a range of possible futures. And it's just hard for the public to accept that. So if we don't communicate that clearly, if we give them any false hope that a single model could predict the future completely, then it's just going to make science look bad, and it'll create a lot of distrust, and this will in turn create a lot of randomness for models. As Meredith mentioned earlier, we made a lot of assumptions on how people would act, and we trusted the public too much in regards to that. So if we were able to reduce that amount of randomness from the public, then we would be able to trust these models much better in regards to like how the public was acting and with masks, with isolation and stuff like that.
Thank you, Meredith and Justin, for explaining the different models and their limitations. Next, we're going to cover the second topic, which is why has it been so hard to measure non-pharmaceutical interventions, even with all of these models and AI capabilities? Next slide. So non-pharmaceutical interventions are actions taken besides getting the vaccine or taking medication to prevent the spread of a disease, and in this case, COVID-19. These include things like wearing masks, social distancing, school closures, lockdowns, stuff like that. Next slide. So as we have all experienced, there's been many factors outside of medicine to help prevent the spread of COVID, but we've all also experienced the inconsistency within these measures. So decisions regarding these interventions were left up to countries, and then even within the United States, they were left up to states, cities, school districts, businesses, and even individuals. For example, with masks, it was at first like a city mandate, and then there was a statewide mandate, and now the governor has said there's no statewide mandate, but it's still up to the businesses. So it's kind of, it's just kind of a mess, and it's hard to keep track of. So situations like this that blur those lines make it really difficult for AI to keep track of these factors, especially when like it's hard for us to keep track of them. Not to mention that just because there is a mask mandate doesn't mean that people are wearing them, and then just because it's lifted doesn't mean that everyone immediately stops wearing masks. So next slide, please. So with intervention, with medical interventions, it's a little bit more straightforward statistics, like the number of people getting vaccines, and then also different medications are pretty regularly documented, like in hospitals and pharmacies. So those records are able to be well managed, but this is a lot harder to do with non-pharmaceutical interventions like masks, the cleaning of public places, because these things are constantly changing and differ so widely across the world. Even if AI could track these things, it's still not clear like who's responsible to keep track of this data and then where they should report that data. Next slide. So a recent study, this study was published like 2 weeks ago, but they tracked 6,000 different non-pharmaceutical interventions in 261 countries, and they organized these 6,000 interventions into 16 different categories, which are shown in this table. And basically, they used Wikipedia articles. So they had a web crawler that every single day checks for updates using keywords from these 6,000 NPIs. And then the data or the article is flagged, and then a human will go in and like read it and then update the data. That's basically the methods of what they did. So next slide. And this is actually a really interesting study that seems to be very beneficial, but it also has its limitations. So the fact that they're able to find and organize data from all over the world specifically about these non-pharmaceutical interventions is really cool and it's really helpful. One of the many examples of data that they're collecting is the different interventions put in place, like in different countries and states. They have the date that things were put in, interventions were like put in place, and then also dates that they were lifted. With this data though, there is definitely limitations. The biggest one being that they're pulling from Wikipedia. So this limits data to only places that have access to computers, and also specifically people that are putting their data into Wikipedia articles. And then of course with that, there's also like honesty and accurate data issues could be a factor because Wikipedia is able to be edited by anyone pretty much. So there could be false data that is put into Wikipedia. The study also cited language barriers as being a potential place for errors because they are using AI and translation. So like there's a place for error there. Yeah, so while AI is very interesting and helpful, there are many limitations and obstacles that Mary is going to further discuss next.
Hi, my name is Mary Cochran, and I'll be addressing some limitations and obstacles that we faced in measuring and modeling the impact of the various non-pharmaceutical interventions. As Riley explained, one obstacle in measuring the impact that becomes immediately apparent is how widely variant these interventions were. Countries and states decided and set the standards for these interventions individually, which means that these decisions are based on several factors, including maturity of health infrastructure, robustness of economy, and cultural values. For example, early findings seem to suggest that poorer nations tended to enforce stricter measures than richer countries did relative to the severity of their outbreaks. For example, the Caribbean nation of Haiti enforced lockdown after its first confirmed case, whereas the United States waited until more than 2 weeks after its first death to issue stay-at-home orders. That may be because lower income countries with less developed healthcare systems act more cautiously. Given that many of these interventions were implemented at the same time, another obstacle in measuring impact is that the results of their effectiveness overlap, making it difficult to ascertain the effectiveness of any one specific intervention. As the other presenters have also mentioned, on top of these issues, an additional problem was the amount of people not adhering to the set interventions. People did this for many reasons, including not taking the virus seriously, believing that it only affected certain populations, or calling into question the efficacy of the interventions, such as the effectiveness of masks, which still has yet to be backed up by definitive data, despite the growing evidence that points towards its effectiveness. The main reason for the lack of definitive data goes back to the previous point that many of the interventions overlap and make it really difficult to distinguish individual results. Next slide. On top of these issues, we also had the typical struggles that come with AI and data, including collection of data, sharing of data, and the interpretation of data. First, the collection of data proved to be difficult for a few reasons, including the lack of accurate reporting. For example, the most accurate representation of COVID deaths seems to come from the excess death estimates, which increased about 22.9% during COVID compared to other years at the same time period. But even this measure has its flaws, with some claiming that only about 72% of those excess deaths could actually be accounted for by COVID. There was also the conflating of antibody and viral tests, which led to the misrepresentation of those who were currently sick with the virus and the rates at which COVID infections were increasing and decreasing. This conflation could easily confuse AI as it tries to determine the effectiveness of interventions. Doing some post-analysis, many researchers also came to the same conclusion and are quite confident that there was a large number of infections that went unreported throughout the pandemic, but especially during the early period, given the rapid spread that doesn't necessarily line up with reported cases. Although unlikely at this high of a rate, this inconsistency, or at least a portion of it, could also be attributed to super spreaders, but more on that a little bit later. Another issue was the fact that tests were not completely reliable, especially in the beginning, with reports of false negatives being as low as 2% and as high as 37% in September of 2020. A recent report in March 2021 also states a positive result on either test meant that it was accurate at diagnosing the infection 99% of the time. However, approximately 16 out of 100 people who are infected will be missed. This could be due to many reasons, including the timing of the test, the type, and the quality of the sample collected. With the chance of these false negatives, and since it also took quite a bit of time to receive the results from this test, this meant that people could be unknowingly spreading the virus. Asymptomatic carriers, difficulties with contact tracing, and super spreaders, which are people who infect multiple people, possibly due to a higher viral load, and possibly even generate new super spreaders, also makes accurate data really hard to collect. Next slide. The sharing of data is also presented an issue in accurately measuring the impact. Because much of our medical data is usually siloed and isolated in incompatible computer systems due to privacy concerns or hoarded by businesses for individual profit, we had a tough time of sharing information initially. While great efforts were made and knowledge was made much more accessible during the pandemic, valuable time was wasted, especially during the onset, when it's arguably most important to get information out quickly, and this even continued on certain locations. There were also difficulties in getting out accurate, unbiased information. Early reports that COVID primarily affected older adults with underlying conditions led to younger people taking it and non-pharmaceutical interventions much less seriously than they should have, and contributed further to the spread of the virus. Next slide. Finally, there were the general problems that come with interpreting data. As I and the other presenters have mentioned, there have been a lot of unknowns and confusing variables when it comes to COVID, something that AI doesn't handle well. In order to process large amounts of data and patterns, there first has to be that large amount of data available, and that data needs to be accurate and unbiased, something that was also lacking as most published works assessing COVID spread and effective interventions have used small, possibly biased, and mostly Chinese and Italian bases. In some ways, the AI could have also been confused by too much available data, leading it to recognize insignificant patterns. This is especially true when it comes to information taken from social media and the internet. As COVID became a bigger issue, the traffic and noise surrounding it accumulated on the internet, which could possibly lead to false conclusions being drawn preemptively, and it becomes way easier to overlook the trends of actual importance. For instance, if you look at AI online shopping models during the pandemic, you would see the mass buying of hand sanitizer and toilet paper, and you might mistakenly think that the public is taking the interventions much more seriously than they actually are based on the people who are panic buying and the people who are buying just to resell at a higher price. So moving forward and evaluating the effectiveness of these interventions in hindsight, and hopefully with the continued sharing of information, AI will be much better prepared in providing accurate measures and models for similar circumstances in the future. So now I'll pass it on to Stephen to wrap up. Thanks.
Good stuff all around. I am Stephen Esposito, and I will essentially be delivering the take-home messages for this presentation. So the first one is that the models early on were all based on assumptions, all right? People didn't expect or didn't behave as they were expected to behave because the US assumed that we would behave similarly to the ways that the people did in Wuhan, China, and the Lombardy region of Italy, when in reality, both of them had extreme lockdowns and travel restrictions early on, and the US did not. And then this concept of population-wide lockdowns and travel restrictions were initially believed to be ineffective. They were thought to be unstable and impossible to maintain, when in reality, this was proved to be only correct under certain conditions, that being it only works with some people some of the time. Next slide. And then there were also a lot of data problems. First off, there was a lack of data because obviously COVID-19 is a novel virus. The closest thing we had on COVID-19 was SARS and MERS because they're both coronaviruses, but neither of them are exactly like COVID-19. There were also questionable data. Most notably, we can look at lockdowns. The case numbers dropped, but why? There were a number of variables. Was it face masks, plexiglass at the grocery store and at the banks, contactless activities like grocery delivery and other food delivery services? The stay-at-home order, no one was pretty much allowed to leave their house unless they had to, or personal cleanliness, a lot of people being more self-aware of clean hands and that antibacterial soaps and Purell purchases went up. Next slide. Also, there's this concept of models versus politics. There was a huge inconsistency between the states. Most notably, their testing rates, sometimes they were up, sometimes they were down, and the turnaround time for results, that being sometimes they came a lot quicker and sometimes they took forever. Also, we had a so-called spring obsession with statistical models. So we really liked looking at the death counts and the hospitalizations over time, when in reality, we should have been looking at how the virus was behaving and evolving a little earlier. And then because based off the death counts and hospitalizations, we were making predictions off of current conditions when in reality, the conditions are changing frequently. And then in terms of the policymakers, they failed to develop a universal, robust testing system and rigorous contact tracing. So because they had so many models coming in from so many different sources, they didn't know what the best possible solution was. There wasn't a one-size-fit-all. Everyone will be happy with this projection and way of handling COVID. Next slide. And then on top of all this, there was mass confusion. Dr. Anthony Fauci, head of the White House coronavirus task force, initially in March of 2020 said no reason to wear a mask. Then a month later, he says wear a mask. And then lockdowns, he referred to the ones in China as draconian and not feasible in the US on March 8th, 2020. And then 1 week later, he opens up, or we become open to a 14-day national lockdown, which I think became a little bit longer. And then the virus itself, the public should not be frightened. It's not. It was referred to as like a mild flu, or maybe a little more serious flu, but a flu nonetheless. And then a month later, he says take the virus very seriously. And then the asymptomatic spread. In January, he said it was never the driver of any previous outbreaks. And then in August, he calls it the driving factor and the thing to be most aware of. Next slide. So at the end of the day, are models useless? No, not really. It's just that effective and accurate ones are hard, but not impossible to come by. It's just that the true challenge is in us, the people, and not only us citizens, but the government and scientists and researchers as well. We need to incorporate, or these modeling companies need to incorporate a teamwork and communication-based model, similar to the one on the right, following that diagram. We need to incorporate good ideas across all the modeling groups. That way, all the voices are heard and we can find a closest to possible, everyone's happy with this solution. And this modeling framework is applicable to just about every outbreak, whether it be a virus one or a pest outbreak amongst agriculture, pretty much every outbreak. Next slide. And that's it. We will now be open for questions.